talking about premature ovarian insufficiency, let's look at this case. This is a very typical case. So this is a young girl, 35 years, fashion designer, smoker, diet mostly packaged food, black coffee, type A personality. I recently came to know what is type A personality. Comes with complaint of scanty and irregular long cycles, irritability, tiredness, and also has concerns regarding her future fertility. Her AMH is 0.3, FSH is 25. So thyroid is normal, TSH is normal. So this is a very obvious diagnosis. You don't need great academicians to make this diagnosis. We can see that the patient is going in ovarian insufficiency. So all this Shweta has covered, that when the ovaries stop functioning before the age of 40 and FSH is high and E2 is low, incidence has increased now. We have been talking about 1% incidence since very, very long time. It is now increased to 3.5 to 4%, in fact. And actually, whatever I'm presenting is mainly the 2024 international guidelines on POI. And these guidelines were made in, these are not ESHRE. They're published by ESHRE, but ESHRE, ASRM, and International Medical Society, they all came together and they brought out a uniform, that's why they're calling it international guidelines. So whatever I'm talking is well documented, so I'm not giving any specific references. You can read, you can download and read the guideline in 2024. So the incidence is actually increased. Other terminology which we use, early menopause 40 to 44 years and late menopause more than 55, this is just for sake of knowing the different terms. What are the concerns? So basically, concerns are of estrogen deprivation, which is major. It's actually head to toe. The whole female body suffers of female sex hormone deprivation because our body is used to estrogens. But majorly heart, bones, muscles, neurological systems, all these where you can see obvious changes because of hormone deficiency. And of course, fertility and childbearing. Risk factors, she has already told you, family members with POI, smoker, toxins in the environment, genetic conditions, I will not go into them, autoimmune conditions. Now, there is a list of autoimmune conditions which increase the risk of POI, but mainly it is adrenal and thyroid. So if there is adrenal and thyroid dysfunction due to autoimmunity, so there is also an additional risk of having ovarian autoimmunity and the patient can go into POI. Causes, again, this is an overlap between risk factors and causes. So iatrogenic, non-iatrogenic, genetic disorders, autoimmune, and of course, idiopathic when we don't know in most patients what is the cause of POI. And here, everybody knows about cigarette smoking and other chemicals. Why I highlighted this is that less people know about the lifestyle we are living and the role of endocrine disrupting chemicals that we are using, things that we are using in our day-to-day life, which actually can lead to POI. What are endocrine disrupting chemicals? These are non-natural chemicals used in consumer products, which we use every day. And the major components which affect the ovaries or even other diseases is bisphenol A, phthalates, pesticides, and so many other. So why do we call them endocrine disruptors? Because they can mimic, block, or interfere with function of hormones. And they have been linked to poor sperm quality, autoimmune disorders, nervous system dysfunction, endometriosis, cancers, metabolic issues, everything. So I think we are actually killing ourselves by a poor lifestyle and using things which are harmful to us. So these are some common sources of EDCs, pesticides, children products. People have now started using in the US glass bottles to feed children instead of the plastic bottles. Other plastic materials, electronics, personal care products, all these have what you call EDCs. And the worst is the kind of, things we use for personal care, makeup, lipstick, all kind of things that we apply on face, they have a lot of EDCs. In fact, like lipstick, they have what they call environmental estrogens, which actually the mechanism is that these environmental estrogens, when there's a long-term exposure, then they actually cause an increased apoptosis of eggs in the ovaries, and that is the mechanism, how they lead to POI. So I think we should go back to nature, less lipstick and common symptoms we all know of POI or hormone deficiency. So mood swings, insomnia, sexual problems, hot flushes occur in about 50%. And all these symptoms are seen in POI, which are basically to do with hormone deficiency. Diagnosis, she has already told you, FSH more than 25. If it is inconclusive, repeat after 4 to 6 weeks. And although in patients who are under 40 showing obvious signs of hormone deficiency, the diagnosis is quite obvious, but the gold standard is FSH. I wanted to repeat that the gold standard is FSH and not AMH. In fact, AMH should not be used as primary test to diagnose POI. It can help confirm if the diagnosis is uncertain on the basis of FSH. And of course, the E2 is low. So diagnosis, she's already talked, iatrogenic, genetic and chromosomal diseases. There's a lot of noise, okay. And autoimmune causes. So autoimmune, like I said, mainly thyroid and adrenal. Now here I wanted to make, or maybe I'll come later. What is the implication for relatives? So female relatives, first degree relatives, sisters, daughters are at high risk of POI. And if genetic cause is identified, then genetic counseling and testing should be offered, like Dr. Shweta said already. And counsel them that either they plan family quickly or they go for fertility preservation. So rather than rushing to find husbands, I think it's a better idea to freeze their eggs while they have some eggs left. This is the risk for relatives. So the risk in population where there are no relatives, it is 3.5%, like I showed earlier. But when there are relatives diagnosed, first degree relatives diagnosed with POI, it goes up to 15%. It's considerably higher in fertility options. Again, she has told a lot of experimental studies about activation of follicle growth in ovarian tissue. You take it out, activate it, reimplant it, administration of stem cells, platelet-rich plasma. But till now, there is nothing which has shown the intervention has shown clear benefit, and therefore it is not recommended for routine use. It should be used for research purposes. So iatrogenic cause, of course, we should be counseling for fertility preservation. So we know that if she's got cancer and she's going to, the ovaries are going to knock off with your treatment, either surgical or chemo or radio, then you go for fertility preservation in terms of egg freezing. Non-iatrogenic cause, by the time patients come to you with POI, there are already no follicles. There are very few follicles, and oof-site freezing is not an option. So it is an option for maybe a sister who is younger, who knows that she carries the gene, but not for somebody who now presents with POI. It is too late for her. So for her, oocyte donation is the only option. Another point to make is that if oocytes are donated by the sister, there may be shared genetic risk and there is a higher risk of cycle cancellation. So she may not be the best donor if she has the same gene. Impact of POI on health, Dr. Shweta has told everybody all these things, but I will just highlight a few things. Women should be counseled regarding increased risk of coronary artery disease, heart failure, and stroke. Of course, donor women need to be seen by a cardiologist, and monitoring at least yearly, call them and check their blood pressure, weight, smoking status, lipid profile, and all that. Bone health, again, POI is associated with poor bone mineral density, and there is increased risk of osteoporosis and fracture. How do we monitor? So the guideline says that you do a DEXA at baseline, and then every 1 to 3 years, depending on the risk factors. And of course, every year you call them and make sure that you sort of reinforce the lifestyle factors. So hormone therapy increases or maintains women with POI. So there is absolutely no question that estrogen should be given to patients who are like, there was a question that she's 38. Well, she's 38, 39, 40, whatever, they should be given because of the risk of majorly heart disease and bones. she definitely should be advised to take hormones rather than not take hormones. Hormone therapy dosage required to maintain bone density should be estrogens at least 2 milligrams oral or 100 microgram patch. Another thing which I want to emphasize here is that when women take HRT at the normal age of menopause, then we go for lower doses of estrogens. But when we are giving hormone therapy to POI patients, the minimum dose is 2 milligrams of estradiol valerate or 100 micrograms of patch, because this is the dose which is required to maintain bone density and to maintain cardioprotection. If patient wants to take a combined pill, that may be an option in some patients, younger ones who want also contraception. It should be given continuous or extended, but not sequential. It is said very clearly, it is written very clearly that when you give sequential, even those 7 days when you're not giving her estrogen actually has a negative effect on her bones and heart. Same goes for HRT or combined pills. Estrogen has to be given every day of the month or year. Also, if you see that when you in a cycling young patient, when they are producing estrogens from their ovaries, the estrogens are never below a normal sort of 50 or something generally. So there is some amount of estrogen in the body all the time. So sequential is not advisable for estrogens. Bisphosphonates only to be advised by specialists. Dietary calcium and vitamin D may be supplemented if required. And HT or hormone therapy should be started sooner than later. If it is started more than 1 year after, then the benefit reduces. So it should be started as soon as possible. With that, question comes to my mind. In fact, a patient came to me who had premature menopause or POI some 7-8 years ago. And I said, how come you've not taken any hormones? She said, nobody advised me. I've been to so many gynecologists. She had about at 37, she had her menopause. So the question that came to my mind, because she said, now I'm fine. My mother also had early menopause, but there's no problem with me now. So I wondered, at the age of, after 7 or 8 years after menopause, should now I prescribe her hormone therapy? So I looked up the literature. I really didn't find the answer. Maybe one of the chairpersons or somebody who's looked up will be kind enough to enlighten me. But I told her that it might still do some good, but probably not as much as if you had started earlier. But to be honest, I did not know what is the right answer to that question. So anyway, genitourinary and sexual health, local estrogen therapy can be added to the HRT, systemic HRT, if symptoms are not relieved. Because local has effect locally and the systemic has, systemically, which is more to do with, it does have benefit on genitourinary system also. But if it is not enough, you can give local, which has more effect on the local genitourinary organs. So lubricant, moisturizer, of course. Another thing, transdermal testosterone can be added to estrogen progesterone to improve libido. But more than 6 months to 1 year, there is no data as of now whether it should be continued or not, or whether it will have any risk or not. So hormone therapy, we all know all these good things about estrogens, that they restore endothelial function and increase HDL, all this decrease plasma glucose. And transdermal estradiol is associated with reduction in triglyceride, whereas oral is associated with increased triglyceride. This is because of the first pass effect through the liver. So these are all good things about hormone replacement therapy. Everybody knows about the WHI study and the nurses' health studies, which were done much, much earlier. With the WHI study, people actually stopped using hormones at all because it showed increased risk of breast cancer. What it showed in those studies was that women who started hormones within a few years after menopause, that is the window of opportunity. So when I say reduction of carotid intima, media thickness, and endothelial function, so they showed that once the carotids have become thickened and like stiff, then giving hormones does not have that kind of benefit for heart disease, as if you reduce the chances or prevent these problems have in the carotids or in general the coronary vasculature. So the earlier, that is why hormone therapy should be started to get the maximum benefit on the cardioprotection rather than late. So threefold increase in ischemic heart disease was observed when the hormone was never used, women who never took any hormone therapy. Women with POI without HT have reduced life expectancy. That is very well documented. HT should be given for primary prevention to reduce the risk. Again, another point, whether they have any symptoms of estrogen deficiency or not. We are not giving hormones to POI patients for correcting hot flashes like we do for usual age, menopausal age women. We are giving it for cardioprotection and bone health. So it should be given whether there are symptoms or not, and should be continued at least till the age of menopause. And at that time, you can actually take a call, the patient and the doctor, whether they want to continue or they want to stop. HT is not contraceptive. The risk of HT, small increase in breast cancer, but if you weigh the benefit and the risk, the benefits outweigh the small risk of breast cancer, because the major mortality is because of cardiac disease. Generally not recommended in women with breast cancer, but women with BRCA1 and 2 without a personal history of breast cancer can be given after risk reducing bilateral surgery.
Sorry to interrupt, Dr. Ambuja. I think please mute yourself.
Risk of venous thromboembolism or DVT. So POI is itself a risk factor for VTE, whether it is idiopathic or surgical. Comparatively, the combined equine estrogens have a higher risk compared to the natural estradiol. Non-oral route has lower risk of VT, we all know that. And if you are using COCs in some patients, then second and third generations have higher risk of VT rather than the first generation, which we sort of discard and say, no, the newer generation are better. But when you talk in terms of or in context of thromboembolism, actually the newer generation ones have higher risk than the older norepinephrine pills. Again, if you're giving them pills, you do not give them sequential, you give them every day. How to prescribe? I think one point I forgot to make somewhere in the slides, that about the thyroid, because there was a discussion on thyroid. So thyroid, these guidelines very clearly say that do not do thyroid antibodies because they are very commonly, they are high in a lot of women who are neither going to have POI or they have POI. So do not do thyroid antibodies, just to TSH. For the simple reason that it is very common in women to find thyroid antibodies. So it categorically says not to do thyroid antibodies. The discussion regarding the fertility, that whether you give thyroxine when antibodies are positive or not, about fertility is a different conversation. But in terms of HRT, in POI, they said you do not do thyroid antibodies. How to prescribe? Very common. First of all, you need to give an adequate dose of estrogen. So at least 2 milligrams of estrogen validate, 100 micrograms or equivalent transdermal spray. So the question was how much spray? So you calculate whatever milligrams, you give that much of spray. Progesterone you can give cyclical or continuous, it is up to you. In younger women, cyclical is better, but when you give cyclic, it is the progesterone which is cyclic, not the estrogen. Estrogen continues every single day. And patient bleeds when you withdraw the progesterone. So generally about 12 days every month. So I tell them every first of every month, 1st to 12th, you take your progesterone, because it's very difficult to otherwise calculate which 12 days. You can take HPA, natural progesterone, LNG IUS, it's the choice of the patient, whatever she wants. And hysterectomized patients obviously don't do it. So hormone therapy must be offered to all women with POI unless it is contraindicated. The sooner it is started, the more it will be. Estrogen must be given continuous, whether it is given as HRT or pills. Progesterone can be sequential or continuous, and lifestyle factors must be reinforced besides hormone therapy at every visit. This is what I said. This is the latest guideline, which all these societies have made a combined guideline. So it is available freely for download.
Thank you so much, ma'am, for re-emphasizing all the points again in a very crystal clear and in a very crisp manner. And very, very nicely you've covered the topic. So over to chairpersons, Dr. R.K. Sharma, sir.
Thank you, madam. It was an excellent talk, and I'm very glad that you brought out endocrine disruptors as a cause of this thing, especially the lipsticks and other things. Even the DDT in the milk. Now since the economic status or the levels of the Indians have increased, so the food intake and the milk intake has also increased, and possibly because of that, the girls are having early menarche.
Absolutely.
And the best of the eggs are, I think they are all, before they get married, they got wasted. And by the time they reach, the marriageable age, as on today, 25 years or, between 25 to 30. So it is not only the number which decreases, the quality also start decreasing. So I think it's very, very important that you brought out that we should, go more natural and try to avoid, we should educate our patients to avoid all these endocrine disruptors. When even a female child is brought early to a gynecologist at any stage, or whenever we say we should give them education about this as a regular basis, so that we can prevent POI also. Thank you very much, ma'am.
Thank you.
Dr. Jyoti Bali.
As usual, whenever ma'am gives a lecture, it's always complete and absolutely crystal clear. So I think it was a very good points brought out from this lecture, that why the incidence has increased, what has changed over the years, as Dr. Sharma rightly mentioned, that the changes with the society, maybe it's with the diet or the cosmetics that we use. EDC, of course, remains one big pointer to the incidence rise in the POI cases.
Dr. Sunita Arora.
Hi, Dr. Shalini. Thank you. So, ma'am, it was a superb talk and complete in itself. So, most important thing, as Dr. Sharma just said, emphasizing endocrine disruptors. So, we keep telling our kids also don't use deos, perfumes, but every left, right, and center, everybody is after these cosmetics. So, it's very, very important. I think we ourselves are also not able to follow the same. Single day, you don't put up lipstick, you don't wear lipstick, you start looking anemic, right? So we ourselves are not able to follow, and it's actually very hard. So ma'am, one or two things, like one, this 21 hydroxylase antibodies. So in cases of POI, we are doing karyotype, we are doing FMR1, Fragile X, and anti-TPO also. Although you said there was a controversial statement, you said anti-TPO is not indicated, but most of the studies, they do support that anti-TPO, especially in infertility cases.
Infertility is different. In fact, the American Thyroid Association does not say even in those cases you give thyroxine, the New York guideline. But this is different. Here they say there is so much incidence of antibodies in normal population that you will be unnecessarily doing TSH all the time.
Yeah, but then there are several guidelines which do support doing anti-TPO antibodies. So I am really not able to reach at a conclusion what we should be saying about this.
Yeah, infertility is a different group.
Yeah, and the 21 hydroxylase antibodies I'm not routinely doing somehow. So does the forum support this? Should we be doing this routinely? What is the opinion of all the seniors here? Dr. Sharma sir, are you doing this 21 hydroxylase antibodies?
I have never done it, this thing. Because,
because what ma'am quoted is from the guidelines.
Yes, ma'am. Yeah,
so the guidelines.
I also don't do it. Basically, the diagnosis is so simple. You do an FSH and E2, and with her history, she is in POI. So actually, we don't need to do this. this is probably if you will find any markers of any endocrine problem, then you will send to an endocrinologist and he would do it, and you might find that, oh, this was actually because of POI also. But for us as gynecologists, we don't need to do these. We need to treat them. That is more important.
Ma'am, I agree.
We were discussing in the last talk by Dr. Shweta regarding anti-TPO antibodies. So coming back to fertility and cases of raised anti-TPO antibodies. So I always involve an endocrinologist whenever anti-TPO antibodies, especially with recurrent abortions and then fertility issues. And I've seen that they say that as soon as the patient conceives, in cases of anti-TPO antibodies, we have to very strictly monitor their, because they are, put on some dose of thyroxine, especially if there is infertility and there is recurrent abortions in these cases. And then they say that, you have to really monitor it very, very closely. And I've seen them monitoring it every 3-4 days also. So,
Recurrent abortion,
not
you
doing,
might give it because we don't have anything else. So we say, okay, whatever you see, at least treat that. But there is no, no guideline says that you have to monitor so strictly. Maybe once in each trimester.
Once in a month one can say. Whenever you have hypothyroidism, once in a month you can do it.
I've seen very senior endocrinologists telling us that it's a very strict monitoring which is needed, especially if the patient is a case of recurrent abortions and having fertility issues and going in IVF.
3-4 days is too early.
Yeah, it is too early.
In a month.
It is too early, but then some senior people, they are recommending this.
जो एल्ट्रॉक्सिन की आप डोज देते हो, कहते हैं जब आप चेंज करते हो तो मिनिमम 3 वीक्स में कराना चाहिए टेस्ट आपको, because that much time to stabilize. तो 4 दिन में वो करके करेंगे क्या?
Just ma'am, I have a question because this point is raised. Suppose TSH is within normal range 2.53 and TPO is high. Will you start thyroxine or you'll just do a follow-up?
No.
The first talk, I think.
See, Sujata, we had a master class under ESAR on this, and we discussed that if anti-TPO antibodies is associated with recurrent abortions, and even if TSH is normal, so guidelines do say adding a small dose of thyroxine in those cases. If you remember, you were also a part of that.
I was remember, but she might.
And we considered all the guidelines. That time we discussed all the guidelines.
Maybe recurrent abortion, maybe you can use that, but not for
recurrent abortions.
Not for infertility.
Because anti-TPO again is a sign of autoimmune condition. So maybe we can consider there. And regarding 21 hydroxylase, I know we all have not been doing it, but after listening to both these talks, should we change and should we, like Dr. Renu Misra ma'am is saying no? Okay, because the guidelines are recommending, ma'am.
It's okay. Guidelines are telling you how to make a diagnosis of the cause of POI. So it's a very exhaustive 250-page guideline. So, I just put it there that it's you trying to find the cause. But
diagnosis is very simple, failing ovarian function, and if you find FSH twice more than 25, diagnosis is done.
Bilkul, absolutely. We don't
need to. So I think we go ahead now. Dr. Dipika, final words from you, and then I'll just take 1 or 2 questions from the chat box.
Yeah, thank you, ma'am. It was a very, very great lecture, everything you covered. And I just wanted to, ma'am, talk about one patient recently where she was an 18-year-old girl coming with irregular cycles and overweight. थोड़ा सा short stature था, तो वो initially I'm just saying that the patient was जैसे PCOS की तरह से management होता रहा because short statured and overweight and 18 years old menarche at 14 years. तो वो with irregular cycles parents लेकर के आए for every 2 months 3 months cycles आ रहे हैं, तो हम Meprid दे रहे हैं and of course at some point of time OC pills. And then finally another for 6 months 7 months ये सब चलता रहा. And then finally the cycles just didn't come for 3 months. Eventually, of course, we did her FSH levels. वो आए ज़्यादा. Then बहुत counseling करने के बाद they went on for the karyotyping. So this patient turned out to be Turner mosaic. So Turner mosaic.
Very typical. They get periods for some time and then they stop.
हाँ जी ma'am. Yeah. So वो बड़ा very difficult counseling to the parents. They just didn't understand.
Difficult.
क्योंकि PCOS उनकी समझ में आ रहा था.
In fact, I also wanted to highlight this point.
इसलिए short है ना, उसका जरूर टर्नर करा लेना चाहिए.
हाँ जी, yes ma'am.
No, ma'am,
Actually,
again, I think we all have seen in our OPDs that many, like the same point Dr. Dipika is saying, many patients come to us with irregular cycles, and the gynecologists think that it is PCOS. So I
Yes.
think right at that point, we should evaluate maybe their FSH only or the antral follicular count just to guide. Because I have seen so many cases, they are being treated as PCOS and they turn out to be POI.
But Dr. Shalini, the latest guidelines for PCOS say कि 18 years old girl, 14 years पे menarche कुछ मत करो, no investigation, no ultrasound is suggested, FSH, LH मत कराओ, सिर्फ testosterone
No, but
कराया,
then if the
TSH.
girl is coming with amenorrhea,
नहीं एमेनोरिया नहीं, irregular cycles थी. Initially वो 2 महीना 3 महीना में cycles आ रही है. फिर उसके बाद वो initially तो वो PCOS का ही thought process था because वो she was overweight.
Last word आया नहीं, हर साल बदलते हैं वो लोग. They can't make their mind.
Just one question from Dr.
Yes.
Misra. Ma'am, is there any correlation with our diet which has changed over the years other than milk?
EDC.
Milk.
Well, डाइट में वही हम क्या खा रहे हैं और क्या उसमें कौन से एंडोक्राइन डिसरप्टर्स हैं नहीं है. As far as possible, have natural food and अपने घर में बना के खाओ.
Ma'am, घर में बनाओ, but the incidence.
bottles are great
I was
also.
just visiting somebody who's a nutritionist, and the cases rising for gluten allergy is enormous nowadays.
And Bisleri bottles are very big.
वो ग्लूटेन ना खाए लेकिन बाकी तो खाएंगे.
सब एक्चुअली
Wheat educated. Wheat nutrition we talked about.
हर कोई खाना खाते हैं.
बिल्कुल. But I think ये एंटीबॉडीज एड्रीनल नहीं कराएं मेरे हिसाब से, लेकिन ये FMRI ये जीन जो है ये करा लेना चाहिए because then it may have implication for the sisters.
Yes.
Daughter
And then
and sisters.
sons. And then again.
Karyotyping and FMRI. ठीक है.
Absolutely.
Dr. Shalini.
So, okay, ma'am, yes, I just would like to read the questions from the chat box. There is Dr. Priyanka Yadav who says, ma'am, I have a 38-year-old patient with POI who has completed her family, her routine investigations and karyotype done. Should I screen her for autoimmune conditions as well, as you mentioned? I have started her on Femistron 2x10 for now. So,
If she has no symptoms of any autoimmune disease, then why do it?
yeah, because karyotype has been already done, and that's what we discussed, that 21-hydroxylase is not to be done.
But
if she has
can
no
do the Fragile X syndrome gene.
Yeah.
डॉक्टर फ्रजाइल का
right.
भी क्या फायदा डॉक्टर साहब, उसने कंप्लीट कर ली फैमिली, उसको
मैम,
एचआरटी
उसकी
से बस
सिस्टर कि अगर वो पॉजिटिव होगी तो उसकी सिस्टर उसकी डॉटर को कराने के लिए.
And again, she continues, Dr. Priyanka, that Femistron 2x10 is a sequential. Okay, that we know. And ma'am, the patient is on HRT, which is started immediately after diagnosis. And should we still advise DEXA scan every 1 to 3 years?
What it says is it depends on the risk factors. If she is very high risk, then you do it. Otherwise, you can do it 3 years in 3 years time.
Yeah,
I will
in
make
fact,
a comment here. It is not for people, I feel for everybody, Indians. 40 May, if you can afford, you should get a DEXA done. And you can definitely mend yourself where your bones are going, bone health is going. So it is not only for premature ovarian failure, it is for all Indian women who can afford should get a DEXA at 40.
in fact, these guidelines say that if DEXA at the time of starting this therapy, if it was normal, then you can repeat it 3 years. But if it was low at that time and you're supplementing it, then probably you need yearly follow-up. What say Renu?
ये discretionary है. देखो, I think we can't have a very fixed sort of thing.
Sure. Okay. So there's this last question, which is role of biphosphonates in already low BMD.
No.
Not in younger patients, I feel.
The hormone therapy has been shown superior to bisphosphonates, but उसके बाद भी अगर किसी का fracture risk बहुत high है और BMD फिर भी low है, तो फिर bisphosphonates हम पता नहीं आप लोग देते हैं, मैं तो नहीं देती. I would send her to an orthopedist.
Yeah,
Orthopedic.
guidelines also do not recommend, ma'am. They prefer this calciums and the HRT rather than this.
मैडम फंडा ये है, अगर आपका BMD नॉर्मल है तब तो आप ईस्ट्रोजन और आप कैल्शियम और विटामिन डी दीजिए.
Vitamin D.
Patient is on a lower grade of osteopenia and osteoporosis, बिस्फॉस्फोनेट्स तो देना ही पड़ेगा कैल्शियम और विटामिन डी के साथ।
हार्मोन के साथ भी
की बात ही नहीं हो रही है। इसको अगर हार्मोन्स आप दे रहे हैं, हार्मोन्स तो डॉक्टर साहब कितने लोग तैयार होते हैं। यस, अगर शी इज लेस देन 40 इयर्स, शी इज गॉट द प्रॉब्लम, देन आप उसको बोलोगे भाई आपने मेनोपॉज तक नहीं लेना है, क्योंकि अदरवाइज आपका हार्ट वार्ट सब चला जाएगा। बट अगर नॉर्मली ऐसे होता है तो ऑस्टियोपेनिया, ऑस्टियोपोरोसिस में बिस्फॉस्फोनेट्स हम देते हैं। वो हम कोई पेशेंट
मेनोपॉज की एज में तो ठीक है।
Okay. So last, I think we've already covered this. To confirm POI, what investigations to be done?
मैडम शालिनी थर्ड टॉक कराओ भाई, ये तो एंडलेस होता रहेगा।
Right, ma'am, right. So thank you all the chairpersons and the great speakers. With this, we move on to the last topic, another interesting topic, IVF pregnancies. Do they need extra care? We have Dr. Vandana Gupta as the chairperson for this. Ma'am is the coordinator for the